So without wasting any further time, let's get started with question number 1. Pretty straightforward. Many a times it's been asked in your exam, but a tinge of difference, right? Now, which among the following surgeries are associated with least risk of post-operative deep vein thrombosis, that is risk of DVT, right? Now, as majority of you know, we have different criteria or different ways of monitoring it, or I would say classifying it. So we can classify the risk of DVT post-operatively. Risk of DVT post-operatively can be divided into 3 categories. We call it as the low risk surgeries, the medium risk surgeries, and the high risk surgeries, right? So I can divide them into 3 categories. Number 1 is low risk, another one is medium, and the last one is high risk surgeries, right? Now, what are the surgeries which are considered to be low risk surgeries, right? All surgeries which are done for oromaxillo, that is orofacial maxillar surgery, that is OMFS surgery, oral facial maxillary surgery, that is OMFS surgery, neurosurgery, and cardiothoracic surgery, that is CT surgery, cardiothoracic surgery. Now, surgeries are classified as medium risk, right? So low risk one is more or less situated in your upper segment of the body, that is orofacial maxillary surgery, neurosurgery, and the cardiothoracic surgery. Medium risk is your inguinal hernia repairs, inguinal hernia surgery, or I will say hernia repair, abdominal surgeries, pelvic surgeries, example like the gynecological surgeries or the gynac surgeries, and the urosurgeries, that is urological surgeries, right? High risk is what you have to remember. I'm going to use a different color to highlight. High risk surgeries are those surgeries. High risk surgeries are those surgeries which involve pelvis and deeper segments, right? So pelvic elective surgery, pelvic both elective as well as trauma related pelvic surgeries, right? This is of high risk. And total knee replacement, that is TKR, and total hip replacement, these are 2 orthopedic surgeries which are of higher incidence with DVT, right? So pelvic and the arthroplasties or TKR, THR arthroplasties are of high risk, right? So these are the 3 categories. Based on this, the question is asked, which among the following is associated least risk, right? We are asking for least risk. So least, we know it is these 3 categories, that is orofacial maxillar surgeries, neurosurgery, and cardiothoracic. Or this option A is cardiothoracic, this is at low risk, so I'm just going to say low. Inguinal hernia is medium, urological is medium, arthroplasty, TKR and THR is of high, right? Of all these, cardiothoracic becomes the best answer. Cardiothoracic surgery becomes the best answer to avoid DVTs, right? Moving on to the next question, question number 2. Which among the following statements regarding surgical drain is false, right? So we're going to talk about surgical drains. Now the option A, in clean surgery such as joint replacements, blood collected in drains can be transfused back. So when you listen to this statement for the first time, you'll feel what absurd is, like how can we transfuse back? But remember, in clean surgeries, right? In clean surgeries, especially in joint surgeries, all joint surgeries are clean surgeries. In clean surgeries, if there is massive collection, also called as rapid collection of blood, massive collection or rapid collection of blood post surgery, number 1. Number 2, if you are using a specialized filter in the drain, so we call it as the filtered drain. So if you have the massive collection, rapid collection, and you are using a filtered drain, then the blood can be transfused back. So transfusion in this criteria is possible. So statement A, that is in clean surgery such as joint replacement, blood collected in drains can be transfused back, which is not a wrong question, right? So the quality and the character of the drain can be used to identify an abdominal complication. It is also a true statement. For example, If you have put a drain in the abdomen and it comes as serous fluid, it is only an inflammatory or I would say the ascitic fluid that is collected. If it is golden yellow in color or greenish tinge, I can say it is bile in color. If it is fecal color, it is like lightish yellow in color or it smells bad, then it is fecal in origin, right? So obviously the quantity and the character, when I say quantity, we have a high output and low output, right? Now, if the drain has very high output, that means the fluid transmission or I guess the third phase flow is pretty high, right? You can assess the conditions. The quantity and the character of the drain can be used to identify abdominal complications, a true statement. Drain should be removed as soon as possible and certainly once the drain has stopped working or become less than 25, right? Now the whole purpose of drain, see, drains are purpose driven, right? They're not simply put. When I say they're purpose driven, that means we put drain for specific surgeries for specific reasons. For example, I put drain in thyroid not to see for infections or any infective collection. I put drain in the thyroid region or post-thyroid surgery to see if there is any reactionary hemorrhage or not. So its only purpose is hemorrhage. Abdomen, of course, I want to see if there is any leak. If I've done some bowel surgeries, I want to see if there is any leak, if there is any other complication, if it is associated with any other collection. It could be an infective collection or an inflammatory collection, to see that across. So in that, I will keep for longer. When I do post mastectomy, obviously I will want that tissue secretions or all the inflammatory or serosanguinous fluid to escape out. So that is for longer time, right? So they are purpose driven. So the drain should be removed as soon as possible because they itself act as needles for infection. So this part is correct. Certainly when the drain has stopped working, obviously if drain is not working, there is no point keeping it. And the criteria of removing it, if it is less than 25 ml, is also correct. So the statement C is correct. So logically, obviously statement D will be the answer. Use of surgical drain. No, I just told you they are the needles of infection, right? So I don't want to iatrogenically induce an infection, but sometimes drain becomes essential, right? You have to weigh the risk and the benefit ratio. In that context, I would say the surgical drains are not increasing. In fact, they're decreasing in recent years. Like we prefer less more often, right? Let's quickly brush up a few important points about surgical drain. Number one, remember by the 7th day of the drain, that means if I put the drain today, that is day 0, by the 7th day, only 20% of drains function. 80% of them do not function. There is no point keeping beyond this point, number one. Number two, as I told you, drains are purpose driven. So in thyroid surgeries, I would like to put the drain only for 24 hours, no more than that. So after 24 hours, if there is no collection, if there is collection, I'll continue. If there is no collection, you can remove the drain. For mastectomy, that is breast surgeries. For mastectomy, I would like to keep for 5 days. As I told you, it is of inflammatory fluid, right? So I want to see whether the seroma collection continues or it grows across. Remember, 5 days is minimum, right? Another important thing is the collection should be less than 25 ml per day in order to remove the drain. In order to remove the drain, I will only remove drain if the collection has come less than 25 ml in 24 hours, or I can say per day, right? If it is an infective collection, for infective collection, for example, patient had appendicular abscess, right? I would like to put a drain. How long will you keep it? Remember, there is no fixed point of time that how long you're going to keep it. For infective collections, keep the drain till it drains. That means I will continue to keep until there is nothing coming out of the drain. So drains are to be kept until they run dry. For bowel surgeries, that is colorectal surgeries. For colorectal surgery, the drains are kept to be around 5 to 7 days at bare minimum, and then based upon the collection. Remember, T-tube is the only drain which I would like to continue for 10 days, right? Now, wherever we use drains, we don't want them to have tissue reaction. We want them to be biologically inert. That is why we're drifting towards silicon drains from latex, that is rubber. The only where rubber is preferred over silicon is T-tube. The reason is because rubber or latex is going to induce tissue inflammation, which will form a tract. I want that tract because when I pull the T-tube out, the tract will facilitate to escape the bile if there is any distal obstruction, number one. Number two, the tract will collapse, fibrose and seal off. So the opening is also sealed. Right, so T-tube is kept for 10 days. That's at a bare minimum. That's at a bare minimum. Remember, before removing any suction drain, before removing any suction drain, always remove the negative pressure first. That means if you have put a drain, for example, Jackson Pratt is a negative pressure drain. We have Romovac, which is a negative pressure drain. So before you are going to remove the drain, you have to deflate. You have to deflate the drain. That means you have to remove the negative pressure. You should take off the pressure. Deflate the drain is also called as off, take off or taking off the pressure. Before you remove it, you should always take off the pressure. And the last important precaution with respect to drains is ICD. While removing ICD, ask the patient to perform a Valsalva maneuver. Valsalva maneuver will make sure no air enters into thoracic cavity. No air gets into thoracic cavity. So these are the few important points with respect to surgical drains, right? So but it's clear, right? Moving on to the next question.
Alright guys, let's move on to the next question. That is question number 3, right in front of you. We had a 58 years old female who underwent a simple mastectomy for stage 1 malignancy, lot of details. During the wound closure, the surgeon encountered the following issue shown in the image, right? And did a corrective procedure. Which among the following statement is false regarding this procedure is the question, right? Now, if you see properly here, the defect that we are encountering here is called as dog ears, right? So this is about dog ears during wound closure. Now, when do we have dog ears? Dog ears are usually seen when you put a spherical incision or a circular incision, right? So when you're closing a circular incision, because of disparity at the corners of the length, it will not close properly and a redundant area will form called as dog ear. So the best way to correct a spherical incision, or I would say a lesion which is spherical, you should always go with an elliptical incision, right? So spherical are the one which results in this. So the elliptical incision are the corrective. Now, what is the rule for the elliptical incisions? Now, for elliptical incisions, we follow a standard rule, that is width to length ratio, right? Now, if width is x, the length has to be 3 times the x, or else the width to length ratio is given as 1:3. The width to length ratio is given as 1:3 in order to avoid dog ears. In the same way, for the suture rule, remember, with respect to the ratio of the wound length, the ratio of wound length and suture material, excuse me, the ratio of wound length and suture material is supposed to be 1:4. It is supposed to be 1:4. There are two important segments, right? Now, let's look at the statement. This is the most commonly seen in elliptical incisions, which is also a correct statement, right? Elliptical incision, it is usually found in spherical and elliptical incisions, more often than spherical. So when we have a spherical lesion, we always go with elliptical incision, right? So this is the lesion that we have, and the incision planned is usually elliptical. Now, it always happens at the corner. If you take it very clearly, right at the corner of the wound, because of disparity in the length, which I've already described you, will result in dog ears. It's a correct statement. Which this condition is also known as dog ears, is a true statement. This is only a cosmetic defect, no functional loss, correct. Skin grafting is an ideal management. No, the ideal management is just the correction of the redundant skin, which you are showed in the image, right? So this is a skin hook that we have. With the help of the skin hook, I'll be able to pull up the dog ear, right? I will excise the redundant skin that is present here, like it's just in the center you have opened. So this is the dotted line that I've shown you is the center right across here. I'm just going to pull it all the way down, right? This is what I've done after I've pulled it all the way down, and I will remark the skin which is right across here, and this much portion of the redundant skin will be removed so that the wound edges are going to get approximated. Then I'll put a suture and it will be closed off, right? So this is the correction for dog ears, right? So remember, dog ears are a cosmetic defect usually seen in electrical incision given for spherical lesions, right? I hope everybody's clear about it, right? So let's move on to the next question. Okay, this is again a pattern of central exams that we are commonly seeing across. Which of the following statement regarding the device shown is true? First, identify the device. This is your harmonic scalpel. Right? This is your harmonic scalpel. Now, look at the harmonic scalpel. This is how you will identify it. You will have a blunt segment which is present here, which is also a transducer. You have two handles, or I can say the finger holders. You will see two tips. So basically it will have two poles. It's also a segment of bipolar segment, right? So there are two poles and a bipolar, right? Now, instruments that uses ultrasound technology to cut the tissue without sealing them. He's asking which of the following statement regarding you are looking for a true statement, right? So instrument that uses ultrasound technology to cut the tissue without sealing them. No, it cuts and seals both. Scalpel vibrates in 2000 to 5000. No, the answer is 20,000 to 50,000 hertz is its vibrating frequency. So this is also wrong. Tissue protein denaturation caused by vibration rather than heat. Correct. It does not use heat. It only uses vibrational technology. This is a correct statement. It can seal and divide arteries and veins of 0.7. No. It can 7 millimeters in diameter. Right. It can handle or it can seal a vessel of 7 millimeters in diameter, not 0.7 millimeters in diameter. Right. So let's do a quick recap on energy devices. We have bipolar, that is bipolar quadri. We have harmonic, and the latest one that we have is the combined energy device. A combined energy device. Now, of course, we also have unipolar, but unipolar is conventional, so I'm not going to talk about unipolar quadri. So we'll compare about bipolar, harmonic, and the combined ones, right? So bipolar, you'll have two poles through which the electricity will be running, and the damage of the tissue, or I would say the effect on the tissue, is limited between those two poles, right? So bipolar combines two forces. One is pressure force, that is the pressure exerted by the two poles that you're pressing, along with the energy source. The energy is generated by the electric current, right? Another very important thing, once you have used a bipolar cautery to seal a vessel, right? Now the vessel is sealed. Normally, when a patient is operated, let's say we're operating in general anesthesia, obviously in general anesthesia, the vessel tone is going to be decreased on purpose, because in fact, entire body tone is decreased on purpose so that you will be able to handle tissue better. The minute the patient comes out of general anesthesia, obviously the pressure inside the vessel will increase. And if that vessel is not sealed properly, it will give away and hemorrhage can happen. That is one of the reasons how hemorrhages happen. But I would like to tell you, when a bipolar cautery seals a vessel, that sealed segment or the sealed tip can withstand 3 times the systolic pressure. So the tip end of the vessel which is sealed can withstand 3 times the systolic pressure in order to be patent, or I would say in order to remain sealed in that segment. If you have not sealed it properly, obviously it will give away, but it can withstand 3 times the systolic pressure, right? We have a latest system in bipolar cautery. We call it as the LigaSure. It's a brand name. Remember, this is very important. LigaSure. It can both seal and divide, right? It can seal up to a vessel of 7 millimeters in size. In fact, harmonic can also 7 millimeters, and combined can also seal a vessel until 7 millimeters in diameter. The only thing that we're looking about, bipolar takes 2 to 4 seconds. Bipolar takes 2 to 4 seconds. Harmonic takes more than 4 seconds. Combined takes less than 4 seconds to seal off a vessel. That is what you have to remember. Now, with respect to harmonic, it uses ultrasonic vibrating energy. It uses ultrasonic vibrating energy. It can vibrate at a frequency of 20,000 to 50,000 hertz, not 2 to 5, which was given in your question right across there. Again, here the hemostasis. Hemostasis is occurred or achieved by protein denaturation. And this protein denaturation is done or is achieved with the help of vibrating energy, not by heat energy. Not by heat energy. Combined one is very important. It uses a principle of both bipolar as well as harmonic. In fact, this is the one that we use for liver dissections and all. Remember, it is trade name is your Thunder Beat. So two trade names that you have to remember. I hope they will not ask, but in this case, one is Ligashore is bipolar and Thunderbeat is combined. It can also seal a vessel of until 7 millimeters in size, right? So this is the bare minimum that you should know with respect to energy devices. With respect to energy devices, right? I hope the question is clear. Moving on to question number 5. Again, a very interesting question, frequently asked in your central exam. All of the following statement regarding the image shown is true except, that means I have to look for a false statement. So I can see there is some sort of a cannula which is going from the chest region. There is another, I would say a plaster that is put, probably that's an opening. And this is the cannula that is going here. There are two ends or two tips which are present, right? So what could it be? This is nothing but a central line. This is nothing but a central line used for total parenteral nutrition. The name of the central line, as you can see, you have two tips. You have exit from here and there is one more incision which is present here, and a part of the cannula is buried under the skin or the subcutaneous layer, and this is called as the Hickman's line. This is referred to as the Hickman's line. So Hickman's line is a type of a central line which has various advantages. We'll talk about it, right? Now let's look at the statements. I am looking for a false statement. Used for long-term parenteral nutrition is correct. Known as tunneled central line, obviously it is tunneled under subcutaneous, obviously called as tunneled central line. Reduces the risk of line dislodgement and line sepsis, that is why we tunnel it. It is also true. Chest X-ray is not required to confirm the position post procedure. Remember, all central lines, irrespective how you put it, requires a radiological confirmation for both your satisfaction as well as for documentation for future purposes. So chest X-ray or ultrasound is must. So D for Delhi, that is chest X-ray not required, is false. Chest X-ray is required, right? Now let's quickly compare the two forms of feeding that we commonly have. One is the peripheral feeding. Another one is the central feeding or the central line, right? So I'm going to talk about the peripheral line and the central line. The peripheral line is further divided into two ones. One is called as the short wrist line. Another one is peripherally induced central catheter, that is called as PICC. Now, a short wrist will survive, or a short wrist cannula will survive only for 12 hours, after which the vein will get thrombophlebitis and it will get occluded or collapsed. So it is not useful. So we take it and put on the contralateral hand, and after 12 hours we put it on the other side also, right? So the lifespan for short wrist is 12 hours. The lifespan for peripherally induced catheter is 7 days, right? When you look at this, I feel we should go for 7 days. But the problem in PICC is your access point is same from a wrist vein, but from there you will guide and go all the way to the central segment. But if this vein undergoes thrombophlebitis, the whole line is gone, right? So there is no other way you'll be able to put somewhere else. Whereas on a wrist one, you can put it here. If this gets thrombophlebitis, you can take an access right at this segment of the forearm. If this is gone, you can take it the cubital vein. If it is gone, you can go to the axilla segment and get some vein right across there. But PICC does not offer you that help. But the only advantage with PICC, it stays for long. Right? Now, remember, peripheral feeding is contraindicated. Peripheral feeding is contraindicated if patient already has a central line. If there is an existing central line, and if patient requires long-term feeding. Now, if you're predicting that patient might require long-term total parenteral feeding, long-term means more than 2 weeks. In that context, we should never go for peripheral line, always prefer central line. Always prefer central line. Now when it comes to central line, we have our preferences. Central line can be put into three veins which are commonly used. Number one is your subclavian vein, then you have your internal jugular vein and the external jugular vein, right? Three veins. Out of these, external and internal jugular veins are positioned in neck. Because they're positioned in neck, it is very inconvenient for the patient and a very discomfort, right? And it's right at the neck. So every time the patient is going to move his neck, what is going to happen? The catheter that you have put can get displaced. There could be the incision that you have made can become widened. What it does is, during the disruption, it can get dislodged, number one. Number two, it also causes an entry point for the bacteria or the infection to get in, causing the line catheter line sepsis is also common finding, right? So with that, internal jugular and external jugular vein have this problem. Neck, because it is going to cause discomfort to the patient. It increases the risk of line sepsis. It also increases the risk of wound infection. Because of these, subclavian vein is preferred, right? But in clinical practice, we still go for the jugulars because it is easy access, right? Subclavian takes a bit of work. So for exam purposes, you have to mark subclavian, which is preferred over internal and external jugular vein, right? Internal and external jugular vein. Now, a variant of the subclavian vein that we candidate from the infraclavicular region, is your Hickman's line. Now, if you look at the Hickman's line, to understand Hickman's line, just a quick feedback, or it's a recap, I would say. This is the clavicle that is present here, and let's say this is the vein that I want to cannulate. What I will do is, I will put an incision right across here and get into the subclavian vein from here, right? Now, once I've gone inside, this tip end where you have your cannulas and there is kind of, a regulator that is at the tip end is present here. So I don't want it to be hanging from here. If it is hanging from right from the incision, what is going to happen? What is going to happen? Again, it will dislodge, again, wound line sepsis, wound line infection, that is very common. So what I'll do is I'll make a counter incision right below here, and I will make sure that my line goes under the skin and comes out from this end, right? So what is done is, it has given me a stability under the skin, that is, the line is safely secured under the subcutaneous plane. And here I also have my regulator, which is also fixed with this sutures here. So this gives me a better, I would say, a hold for the patient. Hickman lines is used if you are expecting a feeding which is more than 2 weeks. Feeding which is expected more than 2 weeks. Remember, you have to do a chest x-ray or an ultrasound to confirm its position. That is very, very important, right? This regulator is also called as Hickman's cuff, right? Hickman's cuff is a regulator that we use. So, right, these are for the peripheral central line, right? You can see the cuff right across here. This is the cuff, right? So this is pretty clear with respect to Hickman's line. All right, guys. So moving to the next one, question number 6. Again, pretty commonly asked ones. These are the venous repair techniques, and you have to match the following. Let's look at it. This first one, that is A. If you look, there is a linear incision. We have sutured it laterally. This is nothing but lateral sutures, right? This, you can see a patch I have put and sutured across, and this is called as patch graft. This opening is called as Carroll. So hence it is called as Carroll technique. These are like panels of graft that I've placed, hence called as panel grafting. And this I have put it in a spherical form that I've just rotated and sutured it. These are called as the spiral graft. So A is 1, B is 2, C is 3, D is 4, E is 5, right? This is the sequence that you have to follow. Let's look at the options. Option A, that is A1, B2, C3, D4, E5, correct. So this is going to be A for Ahmedabad, right? So these are the venous techniques which you have to follow for repairs. Just remember, these images are very important. Okay, moving to the next question, question number 7. Again, match the following with regards to carcinoid tumor. Very interesting. Carcinoid tumor and GIST are two important questions with respect to surgery. They are going to be there in every exam of yours, right? So let's look at the question. So we have carcinoid tumors details and we have the features. For example, pulmonary stenosis. Pulmonary stenosis is seen in which condition? Tumor that arises from enterochromaffin like cells is nothing but carcinoid tumors. So carcinoid tumors is E. So I would say 1 is E. Right? Tumor that arise from enterochromaffin like cells are carcinoid tumors. They are carcinoid tumors. Let's answer here only, then we'll match it. The second option that we have, liver metastasis of the tumor that arises from the enterochromaffin like cells. Right? Now, if a carcinoid tumor metastasizes to liver, we call it as carcinoid syndrome. Right? So this becomes this is carcinoid syndrome. So carcinoid syndrome is a term used when there is metastasis to the liver from the carcinoid tumors, right? It is associated with fibrotic lesions. Now the fibrotic lesions are very, very, very evident, or I would say it is pretty much clear with respect to involvement of bronchus. That is in respiratory words, right? So fibrotic lesions are seen with respect to bronchial carcinomas. Right? Ectopic hormone secretion, weight gain, hypertension, diabetes, all these are associated with Cushing syndrome. With it, Cushing syndrome. Tumors with hypoglycemia, involvement of pancreas, obviously it is pancreatic carcinoid. It is a pancreatic carcinoid, right? Now let's match up. So carcinoid tumor is E. So 1 is E. Carcinoid syndrome is C, right? So 2 is C. Fibrotic lesion, bronchial carcinoids, bronchus and other pulmonic stenosis, that is A. 3 is A. Ectopic hormones, diabetes, Cushing syndrome. Cushing syndrome is D. And pancreatic carcinoids is B, right? So this follows A3, B5, C2, D4, E1, right? D for Delhi. Question number 8. High malignant potential in GIST is determined by. Okay, right. Now, GIST, that is gastrointestinal stromal tumor, depends upon two things. Number 1 is the size of the tumor. Number 2 is the location. And number 3 is with respect to the pathological index that we have, the mitotic count, right? So size plays a very, very important role. More the size, poorer the prognosis. When you talk about the GIST per se, location wise also it will have various impact, like gastric GIST presents very late, right? Intestinal GIST will have early presentation because of difference in size of the lumen, right? Stomach has such a huge size, so obviously presentation is delayed, right? In that context, mitotic counts, again higher the counts per 50 high power field is going to have poorer the prognosis, right? Now here he is asking the malignant potential based upon the size and the mitotic counter. So we have a classification, right? So I can classify the GIST into benign GIST. I can divide them into probably benign, benign GIST, probably benign, low malignant GIST, moderate malignancy, or the moderate risk of malignancy, and high malignant potential. Right? These are the categorization. Now when you look at this, we have benign, probably benign, low malignancy, moderate malignancy, and high malignancy. Now what are the criteria? Now for a GIST to be called as benign, it should be less than 2 centimeters with less than 5 mitotic counts, 5 mitotic count per 50 high power fields. When you say probably benign, the size is between 2 to 5 centimeters, but the mitotic count is less than 5. So 5 mitotic count for 50 high power field. When we say it is low malignancy, in low malignancy, we have size more than 2 centimeters with more than 5 mitotic count for 50 high power field, right? Sorry, size less than 2 centimeters with more than 5 mitotic counts. When we say moderate malignancy, now moderate malignancy, the size can vary between 2 to 5 centimeters with more than 5 mitotic count, with 5 mitotic count, or size can be more than 10 centimeters with less than 5 mitotic count. This is considered to be moderate. When we say high risk, obviously more than 10 centimeters with more than 5 mitotic counts. More than 5 centimeters, more than 5 centimeters with more than 5 mitotic count, or more than same 2 to 5 centimeters, or the size which goes in more than 5 and more than 5 mitotic count. Just for the sake of discussion, I'm completing it. Otherwise, criteria anything more than 5, both more than 5 is considered to be high risk. So this is the size and the mitotic criteria that you have to remember for benign condition, for probably benign, low malignancy, moderate malignancy, and high malignancy, right? Now he's asking for high malignancy, so more than 10, more than 5. What is the option that we have? More than 10, more than 5. So size more than 10 centimeters and more than 5 mitotic count for 50 high power field becomes the choice, right? So GIST again is going to be very, very, very important topic, right? The overall most common site for GIST, is going to be stomach. Remember, usually GISTs are asymptomatic. If they say what is the origin of GIST, it is going to be from the interstitial cells of Cajal. They arise from the interstitial cells of Cajal, which are also called as the pacemakers of GIT. These are again 3 important points that you should remember with respect to GIST. So, moving downward, Meniere's disease in children is associated with all except. Okay, so Meniere's disease, important points, it is idiopathic. It is protein losing disease. It is idiopathic. It is protein losing disease. There are 2 associations that are present. I'm not saying cause. It is associated with cytomegalovirus in children. C for cytomegalovirus, C for children, and H. pylori in adults. Right? It increases the risk of developing gastric lymphoma. The most characteristic feature that you would see on upper GI endoscopy is hypertrophy. It is the hypertrophy of gastric mucosal folds. Hypertrophy of the gastric mucosal folds is the characteristic feature on an upper GI endoscopy. Investigation of choice for Meniere's disease is going to be upper GI endoscopy with biopsy, right? If I say what is the most characteristic feature, then hypoproteinemia. Hypoproteinemia is one of the most characteristic features that you would see in Meniere's disease, right? Management is going to be gastrectomy, that is prophylactic, because it increases the risk of developing gastric malignancy, right? Having said that, now we are talking about in children specifically. It is associated with CMV, correct? H. pylori is associated with adults. No? Peripheral edema, obviously if there is protein hypoproteinemia, there will be edema, correct? Gastric lymphoma increases, or the risk of developing gastric lymphomas is high here. So obviously lymphoma is another option. So answer is going to be B for Bombay. B for Bombay, right? So let's moving on to the next one. Another very important thing, I move on, I just happen to recall with respect to central exams. Remember, Meniere's disease have high levels of transforming growth factor alpha. Remember, this is elevated. This is elevated in Meniere's disease. That's one more point that I want to emphasize, right? So let's moving on. Question number 10. Which among the following neuroendocrine tumors is associated with program? Same as just again neuroendocrine tumors. Again, they depend on size and location, right? So tumor greater than 2 centimeters, and if it is present at a highly vascular segment, it is considered to be a poorer prognosis, right? Now, if you look at this, 1 centimeter is 1 centimeter out of the game, right? Because we want higher size. So more than 2 centimeters are of higher risk. Now, appendix or ileum, which is more vascularized, ileum. So obviously ileum will be a better answer. So D for Dane, right? So neuroendocrine tumors of size more than 2 centimeters and ileum as a site because of high vascularity and high chances of metastasis. High vascularity means high chances of metastasis, right? Now, few important points. Remember, when we talk about the neuroendocrine tumors, the neuroendocrine tumors, if present in appendix, they have a risk of 3% chances of metastasis. Right, neuroendocrine tumors, if present in appendix, their chances of metastasis 3%. If it is present in ileum, the chance of metastasis is 10 times or more than 10 times, that is 35%. If the neuroendocrine tumor is less than 2 centimeters, the chance of metastasis is 2%. If it is between, sorry, not 2 centimeters, if it is less than or equal to 1 centimeter, the chance of metastasis is 2%. If it is between 1 to 2 centimeters, the chance of metastasis is 50%. But if it is more than 2 centimeters, the chances of metastasis is 80 to 90%. Remember this data because it will help you solve multiple questions with respect to same analogy, right? So very important topic, neuroendocrine tumors per se, right? Just make sure you read it up yours, right? So move to the next question. Question number 11. Which of the following factors prevent a spontaneous closure or a spontaneous intracutaneous fistula closure except? So we are thinking or we are looking in terms of factors that allow the closure of intracutaneous fistula, right? Now, all of the following is a factor preventing, right? Except, remember, a low output fistula and a medium output fistula will close, a high output fistula will not close. The high output fistula is more than 500 ml for 24 hours. Now, just for a quick recall, factors that prevent the closure. Number one factor is going to be a high output fistula, which is more than 500 ml of output in 24 hours, right? Number two, if more than 50% of the bowel circumference is injured, if more than 50% of bowel circumference is injured, that is again because of severe disruption. This is also called as severe bowel disruption. This is also severe bowel disruption. If patient has an active inflammatory bowel disease like Crohn's and ulcerative colitis, here Crohn's will have a greater deal when compared to ulcerative colitis, right? If patient has an active malignancy which has resulted in intracutaneous fistula, so obviously it will not going to be closed. Radiation enteritis, presence of distal obstruction in the fistula which will not allow the secretions to escape properly, right? Undrained abscess, if the length of the fistula tract is more than 2.5 centimeters, sorry, less than 2. Shorter tracts will not heal completely or will not heal at a greater pace. Longer tracts can because they collapse, right? So length less than 2.5 centimeters and epithelialization of the tract. Epithelialization of tract will prevent the spontaneous closure, right? Now, these are the reasons why that will not allow spontaneous closure of intracutaneous fistula. Now, when I said high output fistula, for those who are wondering what are the other types, we have low output also. Low output, if it is less than 200 ml in 24 hours, then we have intermediate or moderate, which is around 200 to 500, So low output is less than 200, intermediate is 200 to 500. Right? Now, all of the following factors prevent spontaneous closure except low output fistula. This is not 200 is low output. So obviously it will allow the closure, not stop, right? So answer is this. Radiation enteritis will not allow, epithelialization will not allow, and undrained intra-abdominal abscess will also not allow the spontaneous closure, right? So this is again a very important topic. Intracutaneous fistula is again a repeat question in your exam, right? Do remember a process. Sure. Okay, match the following again, right? Again, multiple questions. We have scoring systems in pancreatitis and we have the cutoff value. Pretty simple, right? Now, APACE 2 scoring system. APACE 2 का criteria क्या है? More than or equal to 8 points should be present in the first 24 hours or within 24 hours, right? That is for APACE. Ranson's का क्या है? Anybody? Ranson's का it's if the score is more than or equal to 3 in the first 48 hours, within the first 48 hours. BISAP का क्या है? Anybody? BISAP is again more than or equal to 3 within 24 hours, right? Modified Glasgow का क्या है? Anybody? Modified Glasgow, again it should be more than or equal to 3 but within 48 hours, right? You match it across. So where do you have 8? This is R, right? Where do you have 3 in 48 hours? 3 in 48 hours we have Q, right? We have more than 3 in less than 24 hours, less than 24 hours. In the first 24 hours it is going to be P. 3 in 48 hours is going to be, 3 in less than within 48 hours is going to be S. We have already used this. So 1 is R, 2 is going to be Q, 3 is P, 4 is S, that is A. A for Ahmedabad, right? Now let's look at the cutoff values for all. For acute physiological and chronic health education 2, that is APACE scoring system, a total of score of more than 8 in the first 24 hours is considered to be evaluatory for acute pancreatitis. Second scoring system that we have is BISAP. The BISAP scoring system, the score should be more than or equal to 3 in the first 24 hours. Then we have the modified Glasgow scale. A modified Glasgow, MGG is modified Glasgow. The other name for modified Glasgow, this is an expected question, okay? The other name is called as the IMRI score. Modified Glasgow is also called as IMRI score. Here it is more than or equal to 3 in the first 48 hours. In the first 48 hours, then we have Ranson's. Ranson's is more than or equal to 3 in first 48 hours, right? Again, two important more points. Urea at the time of admission. Urea at the time of admission should be more than 60 millimoles per liter. 60 millimole per liter, and the C-reactive protein more than 150 in the first 72 hours, right? This table will fetch you at least one question in the upcoming exam, right? Keep an eye on it. These are the scoring systems. Scoring system in acute pancreatitis. Scoring systems in acute pancreatitis, right?